Diffuse alveolar hemorrhage syndromes happens as a complication of some interstitial lung disorders. Goodpasture syndrome, idiopathic pulmonary hemosiderosis, and granulomatosis with polyangiitis are considered pulmonary hemorrhage syndromes. Goodpasture syndrome is an uncommon autoimmune disease in which the lung and kidney injury are caused by circulating autoantibodies. Those autoantibodies are against certain domains of type 4 collagen, which are intrinsic to the basement membranes of the renal glomeruli and pulmonary alveoli. The antibodies triggers destruction and inflammation of the basement membranes in the pulmonary alveoli and the renal glomeruli, giving rise to the necrotizing hemorrhagic interstitial pneumonitis and the rapidly progressive glomerulonephritis. Grossly, the lung shows areas of red-brown consolidation due to the diffuse alveolar hemorrhage. Microscopically, focal necrosis of the alveolar walls associated with intra-alveolar hemorrhage, fibrous thickening of the septa, and hypertrophic type 2 pneumocytes are seen. Abundant hemosiderin can be seen due to the earlier episodes of hemorrhage. The alveolar septa show the characteristic linear pattern of immunoglobulin deposition, usually IgG, sometimes IgA or IgM, which is the hallmark diagnostic finding in renal biopsy specimens. This figure shows the histologic features of a lung biopsy from a patient diagnosed with diffuse alveolar hemorrhage syndrome. As you see, the yellow arrows points to the large numbers of intra-alveolar hemosiderin-laden macrophages. The black star points to the background of thickened fibrous septa. The tissue in the previous figure has been stained with the Brassain blue, which is a special stain used to highlight hemosiderin. An abundant intracellular hemosiderin in this figure is highlighted by the blue color. Most cases occur in patients in their teens or 20s with male predominance. The majority of patients are active smokers. Plasmapheresis removes the offending antibodies, and immunosuppressive drugs inhibit the antibody production. With severe renal disease, renal transplantation is eventually required. Granulomatosis and polyangiitis, formerly called Wigner granulomatosis, in this condition more than 80% of patients develop upper respiratory or pulmonary manifestations at some time in their course. The lung lesions are characterized by a combination of necrotizing vasculitis or angiitis and a parenchymal necrotizing granulomatous inflammation. So the signs and symptoms stem from the involvement of upper respiratory tract, so the patient may present with a chronic sinusitis, epistaxis, nasal perforation, and the lungs, so the patient may present with cough, hemoptysis, and chest pain. PR3 ANCA, which is the antineutrophil cytoplasmic antibodies, are present in close to 95% of cases.